This lecture is on hemorrhagic stroke. I've divided ischemic and hemorrhagic stroke just so that you can digest the content a little easier, and you'll notice that this slide deck is much shorter. I just want to acknowledge Dr. Michael Kelly and Rima Dafer, who gave the in-person talks last year for both of these, and I have used some of their slides. So these are the lecture objectives. You want to be able at the end of this to describe the types of strokes and their relative incidence, and this is of course an objective of the prior lecture on ischemic stroke. You want to describe the two types of hemorrhages, describe the presentation clinically of a subarachnoid hemorrhage. You need to be able to define the term aneurysm and describe the two types that you will need to know in this block, and you need to be able to define an arteriovenous malformation. So this slide is a repeat from the ischemic stroke lecture, and what you can see is that hemorrhagic stroke makes up about 15% of all strokes, so it is less common. Of those patients who have hemorrhagic stroke, 70% of them have an intraparenchymal bleed, and 30% of them will have subarachnoid blood. Let's start with intraparenchymal hemorrhage. This occurs when there's rupture of parenchymal blood vessels with local tissue destruction and mechanical distortion. It is most secondary to the vascular changes of chronic hypertension, such as lipohyalinosis, fibrinoid degeneration, and microaneurysms. There were other causes to include arteriovenous malformations, neoplasms, amyloid angiopathy, and coagulation disorders. Here are some pictures of intracranial hemorrhage. What you can see on the left, and we also will contrast it with subarachnoid hemorrhage. So what you can see on the left is if we take a coronal cut, meaning you take a look looking from the front of the head back, you can see here on our coronal cut a bleed that's within the parenchyma of the brain. And so this is an intraparenchymal or intracranial hemorrhage. Below is the same cut, a coronal cut, but we're looking at subarachnoid blood, and you can see that the blood is sitting within the subarachnoid space. Over on the right, we see some additional pictures illustrating the location of the blood either within the cortex itself, intracerebral or intraparenchymal, versus blood within the subarachnoid space. Now the two pictures below, the subdural and epidural hemorrhages, we're going to come back to when we discuss traumatic brain injury, although I think you will have some pictures of this when we do pathology. Here are some imaging studies of patients who have intraparenchymal hemorrhages. On the left, you can see blood, which looks bright on our CAT scan, and this is located in the thalamus. So this is a CT scan. You can see that it looks like we're looking at an axial cut of the CT scan. So we've cut the top of the head and taken it off, and we're looking down. On the right, we see a much larger bleed. And you can see not only do we have blood that's located in the basal ganglia, but we also have some blood that's layering within the ventricular system that you can see down here in the ventricle. And the reason why it's layering down that way is because the patient's laying flat on their back to get the CT scan, so the blood is kind of falling down to the back of the ventricle. Here are some more pictures of intraparenchymal hemorrhages. On the upper left and bottom right, you can see the path pictures. Again, this is another coronal cut on the upper left, and in the bottom right, we have a hemorrhage within the pons. So the brain stem is not protected from these. You can have a bleed anywhere within the central nervous system. On the upper right, we see another CAT scan. Again, blood is going to be bright on our CAT scan. And on the bottom left, you can see that this is an MRI. So if you look at this, you can see we have a much better definition of the gray and white areas. You can see that the eyes and the nose in the top of the picture. And what you can see in the brain parenchyma itself is this white signal, and this is blood on the MRI scan. So let's talk a little bit about subarachnoid hemorrhage. So this is when you have a rupture of an artery within the subarachnoid space. You will frequently have destruction of the adjacent brain parenchyma and obstruction of CSF flow by clotted blood, and this can result in a hydrocephalus, typically a non-communicating hydrocephalus. The other thing that will happen with subarachnoid hemorrhage is that blood is quite irritating to a lot of the vascular structures, and you can have delayed vasospasm and resulting brain ischemia that is secondary. So you can start with a subarachnoid hemorrhage, have vasospasm of a vessel, and then have an ischemic stroke on top of that. So you can see why this is going to be quite serious if this occurs in your patient. Most subarachnoid hemorrhage is from the rupture of congenital berry aneurysms, although you can get subarachnoid bleeding from arteriovenous malformations, coagulopathies, or trauma. So the clinical signs of subarachnoid hemorrhage cannot be missed, and I have noted that this is something that will be on step 1 and is considered a red flag if you hear this history from a patient. The patient will say they have sudden onset of the worst headache of their life, and it's described as a thunderclap headache. It comes on acutely. It can wake the patient from sleep. The patients can have a variety of different symptoms depending on where the subarachnoid hemorrhage is occurring. Frequently, because of the sudden release of blood, they will have nausea and vomiting. They can have photophobia, neck stiffness, encephalopathy, cranial nerve abnormalities, focal weakness, or can go directly into a coma. This is a neurological emergency and has an incredibly high fatality rate. So if you hear this history from somebody, especially who's not already in the hospital, you need to immediately get them transported. Approximately half of patients will die from a subarachnoid hemorrhage before they receive medical care. Now, I would tell you not every patient who presents with a subarachnoid hemorrhage will have acute decompensation. So after I took my course as a first-year medical student and learned about subarachnoid hemorrhage, I encountered a patient in the emergency room when I was a third-year student who said that they had the worst headache of their life. So I immediately wrote this down after I did my neuro exam and saw I couldn't really find anything in the neuro exam. I reported this to my attending physician in the emergency room. And I said, well, I had my lecture a couple years ago on subarachnoid hemorrhage, and the patient is saying they have the worst headache of their life. And the attending emergency room doctor said, well, what's their exam? And I said their neurological exam is normal. And the emergency room doctor said there is no possible way this patient has a subarachnoid hemorrhage. So we went ahead and did a CAT scan of the patient's head just to rule out if there was anything going on, and what do you know, the patient had a subarachnoid hemorrhage. So that particular patient ended up being admitted to the hospital, and we did not find the cause of the subarachnoid hemorrhage. It was kind of a sporadic hemorrhage without an aneurysm that we could locate. So if you hear worst headache of their life, you want to think about other causes of headache as well, but you would first want to rule out that the patient has subarachnoid bleeding. Here are some pictures of what a subarachnoid hemorrhage looks like, and what you can see is that the blood is kind of layering around here. It's this white piece, and so it's sitting in the subarachnoid space, and it looks very different than those round sorts of hemorrhages we saw with the intraparenchymal hemorrhage. Over here you can see the blood is layering around the brainstem. Down in here it's layering around, again, the sulci. And here we can see a picture in this particular patient of an aneurysm that likely ruptured. So let's talk a little bit more about aneurysms. This information will also be on step 1. So an aneurysm is defined as an abnormal dilation of an artery due to weakening of the vessel wall. And there are several types of aneurysms. You can see pictures here on the right. Here's a saccular aneurysm, a fusiform aneurysm, and a ruptured aneurysm. That's kind of what it looks like. On the bottom, you can see this big abnormal aneurysm sitting here at the bifurcation. And actually, this kind of looks like a little person if you look at it. Kind of look at the profile. But this is quite large, and this obviously is not ruptured yet. So there's 3 types of aneurysms. There are 2 that are likely to be on your STEP exam. The first are the Charcot-Bouchard microaneurysms. And these are seen in patients who have chronic hypertension, and they're found in small vessels. So we'll typically see them in the lenticular striate vessels and can lead to basal ganglia stroke. We frequently will not see these in angiography because they're so small. They're microaneurysms. The fusiform aneurysms are this appearance up here, and I won't go into much detail with those, although we do treat them differently. And finally, you will see the saccular aneurysms up on the upper right as well. So let's go into some more detail on the saccular aneurysms. So the saccular or berry aneurysms occur at bifurcations in the circle of Willis, and the most common is at the junction of the anterior communicating and the ACA, anterior cerebral artery junction. These tend to be clinically silent until they rupture unless they're compressing structures that are very close. So there are 3 syndromes that are likely to show up under step 1 exam that we have not covered in other parts of the course. So I'm going to just briefly talk about them here. So an anterior communicating compressive aneurysm is going to cause a bitemporal heminopia. And we will learn in our next case about the visual fields. But the reason why we have a bitemporal heminopia is because we're compressing the optic chiasm from the location of the anterior communicating artery. These patients will also have visual acuity defects. We will infrequently see bitemporal heminopia. So if you see this, you need to be concerned that there's something going on right around the optic chiasm. If you have a rupture of an anterior communicating artery aneurysm, you frequently will have ischemia in the distribution of the anterior cerebral artery. So you have contralateral lower extremity hemiparesis and sensory defects in the same area. A posterior communicating compression is very commonly tested, and it is associated with an ipsilateral cranial nerve 3 palsy. And if you remember from our gross brain lab, cranial nerve 3 sits right next to the PCOM. And so if you've got an aneurysm on the PCOM, it's very likely you're going to press on that nerve as it courses. Now, you want to make sure you remember that a cranial nerve 3 palsy is going to be associated with a down and out pupil, or what we call a blown pupil. A blown pupil or a down and out eye. There are some risk factors for the formation of aneurysms. Women are more likely to have aneurysms, older women especially, so women with increasing age. Family history of unruptured aneurysms, hypertension, smoking and alcohol use, and there are several rare diseases and genetic diseases that are associated with aneurysm formation. Off here on the right are some typical locations for aneurysms. So you can see the anterior communicating and posterior communicating locations, top of the basilar, internal carotid, and then down here on pica, the posterior inferior cerebellar artery. Just a few words about arteriovenous malformations. So these are vascular abnormalities that are fistulous connections of arteries and veins without the normal intervening capillary beds. And what you can see in a couple of these images, so on the upper right, you can see what looks like a bunch of snakes sitting in the cortex. That's actually that connection between the arteries and the veins. We can see it down here where we see this kind of dark signal abnormality, and then this is on angiogram. You can see kind of this mess. During the arterial phase where you're seeing all the arteries, you're also seeing that blood leak into the venous system. And the bottom right here, we have kind of a close-up picture of what one of these looks like. So let's talk a little bit about unruptured aneurysms and vascular malformations. So on the left here, we have a table, and I've removed some of the other abnormalities that we see. So unruptured aneurysms and arterial malformations are the two that we're going to want to focus on. And what you can see is that they're frequently acquired. Unruptured aneurysms tend to be either asymptomatic or they're going to compress on structures around them like we've already discussed. Arteriovenous malformations, because they're located in the cortex, will frequently present with seizures and hemorrhage, and you will see focal neurological deficits. Occasionally you pick these up incidentally when the patient's being scanned for other things. So for unruptured aneurysm, really the best way to see them is by imaging of the blood vessels. So a magnetic resonance angiography, where you don't actually squirt dye up from the groin. You actually do an MRI, but take a specific look at the vessels. AVMs, you tend to also want to image the parenchyma itself, so you're going to order an MRI as well. The risk of hemorrhage is variable with unruptured aneurysms depending on the patient's risk factors. AV malformations bleed about 2 to 4% per year. And then risk factors for hemorrhage. The strongest risk factors for unruptured aneurysms are size and location. And for AVMs, it's a history of a prior hemorrhage or presence of an associated aneurysm. So if you look over here on the upper right, you see the 5-year cumulative rupture rates according to size and location. And again, as I just said, the size matters here. And so the bigger the aneurysm, the more likely it is it's going to rupture and bleed. And so frequently, if you're going to treat an unruptured aneurysm, you're going to want to do it before it gets to this very large size if you can. So what is the treatment for these? So the treatment is surgical. And so we heard from our neurosurgeon in the gross brain lab. This is the type of work that he does. So you can open the patient up and do surgery, or you can do it stereotactically, where you attach a frame to the patient's head and you can kind of manipulate tools into a smaller area of the brain rather than opening them up directly. Finally, you can do endovascular embolization, where you go into the blood vessel and you can either put some glue in there, we call it glue, you can put a stent in there, or you could put other things in there to close off the aneurysm. So the summary is that hemorrhagic stroke is less common than ischemic stroke, and the two main types are intraparenchymal and subarachnoid. Subarachnoid hemorrhage is a high fatality and cannot be missed, so you need to know those clinical signs. Aneurysms and vascular malformations are common causes of hemorrhage, so you need to know a little bit about each of them.